All right. Hi, everyone. Just going to give it a minute while everybody joins from the waiting room. Then we'll go ahead and get started. All right. Thanks, everybody, for joining us. Welcome to our webinar titled "The World is Running Out of Antibiotics." My name is Melissa, and I'm just going to quickly introduce our presenters before we get started. We're hosting this webinar today to mark two events that are happening this week, actually. Excuse me. World Antimicrobial Awareness Week, which you'll learn more about during the presentation, and Memorial University's Research Week, the goal of which is to celebrate and raise awareness of Memorial's internationally renowned research expertise and encourage more multidisciplinary collaboration among the research community. As we go through the presentation today, I'll encourage you to use the chat or the Q&A feature to ask questions, and we'll have some time for a Q&A after the presentation is over. You may also wish to turn on captions by clicking the CC button at the bottom left corner of your screen. I will note that those captions, of course, are auto-generated, so there may be some little mistakes in there. Our presenters today are Robert Wilson and Dr. Peter Daley. Robert has a PhD in clinical epidemiology and is the program manager of Quality of Care NL. He's also an adjunct professor in the Division of Community Health and Humanities here at Memorial's Faculty of Medicine. Dr. Peter Daley is an infectious disease physician, a medical microbiologist, and an associate professor of medicine, infectious diseases, at Memorial's Faculty of Medicine. He's also a co-chair of the Provincial Antimicrobial Stewardship Committee. So right now I'm going to hand the mic over to Robert to get us started.
Thanks, Melissa. So you can just go to the next slide there. So I briefly just want to discuss a bit of a background of what Quality of Care NL is. So what we are is an applied health and social systems research and evaluation program, and we're aimed at improving the quality of care delivered to the people of Newfoundland and Labrador. And so we've kind of adopted the mantra of that we want to ensure that the right treatment gets to the right patient at the right time. So, but we also have a partnership with Choosing Wisely Canada, which establishes national guidelines and recommendations across many disciplines within the healthcare system. And their mantra is to reduce low-value healthcare, particularly when it harms outweigh benefits. And so all the work that Choosing Wisely Newfoundland that you see perhaps across the work that we've done is carried out by Quality of Care NL. So you can go to the next slide, Melissa. So like I mentioned, we are a research and evaluation program, and we're centered on health and social care system priorities, and it's directed by many people within the healthcare system. These projects can be initiated by many healthcare providers. It can be policy decision makers. It can be patients, because we work closely with patient-oriented research. And basically is what we're trying to do is improve the delivery of healthcare and social care to the people of Newfoundland and Labrador. And what we do is, we define the methodologies, we analyze data, and one of the main things that we do is provide clinical interpretation. And along those projects, we try to engage patients to ensure projects' outcomes are quite meaningful to the population. And then we work with and engage all stakeholders to encourage the implementation of evidence-based research and evaluation outcomes so that the best care or service is provided to the people. So you can move to the next slide, Melissa.
Okay, I'll take over from here. My name is Peter Daley. So I am an infectious disease physician and responsible for antimicrobial stewardship in the province of Newfoundland and Labrador. Thanks for joining us today. Some of you may be familiar with our topic today. I see some names on the attendees list that are healthcare providers, and some of you may be joining us through Memorial University. You may be students. You may be unfamiliar with this problem that we face in healthcare, which is called antimicrobial resistance. We're going to give you an introduction to this problem today. We're going to give you some possible solutions, but we want you to come away with some concern that we have an ecological problem within medicine, which has to do with progressive loss of efficacy of antimicrobial treatment. And by way of introduction, most medicines we use in science and health keep getting better and better. We find a better medicine and we get rid of an old medicine, but the progress is always towards better and better. However, in this field, which is infectious diseases, we are disturbed that the progress or the trend is the opposite direction. We are finding that antibiotics or antimicrobial drugs are becoming less and less effective as the bacteria, viruses, fungi, and parasites that we treat that cause human disease are becoming more and more resistant. So we're concerned that we're facing a kind of a global warming problem, if you want to compare it to that has many factors and contributors, but it's responsible for more than 1 million deaths per year globally, and more than 5,000 deaths in Canada per year. And so, we have big priorities that emerge, like new viruses that cause millions of deaths, but these pandemics go away. And this problem continues to progressively worsen over years of time, which is antimicrobial resistance. So I'm going to start with a little introduction video, and we're going to watch this for a few minutes that talks about what are these drugs and why are they no longer working. Let's play the video.
Sorry about that, folks. Could you hear that audio on the video?
I could not hear the audio.
My bad. Give me just 1 second. I'll have to reshare that for you. Now it should work once we get going.
I can hear it.
Antibiotics. Behind the scenes, they enable much of modern.
I'm sorry about this, guys. I'm not sure what's
Try it again because it worked. If not, we'll go past it. Okay, let's see if we can get that video going, but if we can't, that's also okay too. The video really explains how antibiotics work and what is the progressive problem. Let's try it one more time.
Antibiotics. Behind the scenes, they enable much of modern medicine. We use them to cure infectious diseases, but also to safely facilitate everything from surgery to chemotherapy to organ transplants. Without antibiotics, even routine medical procedures can lead to life-threatening infections, and we're at risk of losing them. Antibiotics are chemicals that prevent the growth of bacteria. Unfortunately, some bacteria have become resistant to all currently available antibiotics. At the same time, we've stopped discovering new ones. Still, there's hope that we can get ahead of the problem. But first, how did we get into this situation? The first widely used antibiotic was penicillin, discovered in 1928 by Alexander Fleming. In his 1945 Nobel Prize acceptance speech, Fleming warned that bacterial resistance had the potential to ruin the miracle of antibiotics. He was right. In the 1940s and 50s, resistant bacteria already began to appear. From then until the 1980s, pharmaceutical companies countered the problem of resistance by discovering many new antibiotics. At first, this was a highly successful and highly profitable enterprise. Over time, a couple things changed. Newly discovered antibiotics were often only effective for a narrow spectrum of infections, whereas the first ones had been broadly applicable. This isn't a problem in itself, but it does mean that fewer doses of these drugs could be sold, making them less profitable. In the early days, antibiotics were heavily overprescribed, including for viral infections they had no effect on. Scrutiny around prescriptions increased, which is good, but also lowered sales. At the same time, companies began to develop more drugs that are taken over a patient's lifetime, like blood pressure and cholesterol medications, and later antidepressants and anti-anxiety medications. Because they are taken indefinitely, these drugs are more profitable. By the mid-1980s, no new chemical classes of antibiotics were discovered, but bacteria continued to acquire resistance and pass it along by sharing genetic information between individual bacteria and even across species. Now, bacteria that are resistant to many antibiotics are common, and increasingly, some strains are resistant to all our current drugs. So, what can we do about this? We need to control the use of existing antibiotics, create new ones, combat resistance to new and existing drugs, and find new ways to fight bacterial infections.
Yes, so thanks for sharing that video. And I think that's a lovely introduction to the problem. Why are we worried right now? What is the concern? We are running out of these drugs, and the pharma companies are not motivated by profit to sell these drugs, and so they are not creating new antibiotics for us. What does this mean? If you're familiar with healthcare, you're familiar with the first antibiotic we select for the patient may not help the patient at all. In fact, it may be incorrect based on the germ that we grow from the patient who is in hospital with a life-threatening bacterial infection. And so on World Antimicrobial Awareness Week, we like to have a public message which shares the concern with people who live in our province that antibiotics are precious. We are wasting them by using them inappropriately, and we need to find ways to reduce their usage. Of course, we need to address antimicrobial resistance in other ways, as the video also said: better vaccines, better diagnostics, better surveillance. But reducing inappropriate antimicrobial use is our primary direction in human health. As we're going to talk about today, we're also concerned about antibiotic use in animals and in agriculture. And all of these usage problems contribute to this progressive ecological problem. So happy World Antimicrobial Awareness Week. You may see some prominent buildings that are lit up in the color blue this week, including the Confederation Building and the Health Sciences Center, because the color blue represents this problem. And we want people to become aware of this problem, share this problem with your family, and maybe consider changing your approach to requesting antibiotic treatment when you may not need it. Next slide. So this problem is increasing, and here's some facts to help you understand the scope. 5 million human deaths worldwide associated with bacterial antimicrobial resistance, which is a big global problem. In fact, it's getting up to the scale of tuberculosis, HIV, and malaria in terms of global infectious disease concerns. We know that the pharmaceutical company has to spend a lot of money and a lot of time in creating a new antibiotic, and it's not easy to do. And the market that they get after they create a new antibiotic is limited in profit to them. We also know that we have environmental contamination with antimicrobial resistance, that the resistant germs that you and I shed into the environment, that we acquire from the environment, are already drug resistant, and that these genetic determinants can be shared between germs and between humans and animals, between animals and environment, between environment and humans. So this is really an ecological problem affecting far more than simply human health. We know, for instance, in agriculture and raising of animals for food, like beef or pork or chicken, that antibiotics are beneficial in that they increase profit to these industries, which create meat for food. And therefore, there's a strong incentive to use these antibiotic drugs in these animals, not to treat infection, but rather to promote growth of animals, which we do consider to be an inappropriate usage and are also worried that it's contributing to the problem of antimicrobial resistance globally. Next slide. And we have some financial estimate of the scope of this problem. And we're expecting that by the year 2050, that antimicrobial resistance will reduce the global production, the global GDP by 3.8%, and that could be up to $3.4 trillion per year, and could unfortunately push 24 million people into extreme poverty. You see, we live in a rich country and we have a threat of this to health, but far more important in a low and middle income country where antimicrobial resistance is more common and people are closer to poverty to begin with. So where antibiotics may begin to fail to treat bacterial infections, this may have a significant global economic harm to the most vulnerable populations. We know that antimicrobial stewardship is a big part of our focus, but many other things can also contribute. We can prevent transmission of these antimicrobial resistance germs by doing simple things like washing our hands, taking proper vaccination, staying home when we're sick so we don't spread germs to each other, focusing on high-risk areas, for instance, daycare of children, where there's a lot of germs that are transmitted in between children. And we're also considering the contribution of things like access to clean water. So especially in low-income countries where there is contamination of food and water with bacteria, simple sanitation and hygiene measures, which are not available to these populations, could significantly benefit the problem of antimicrobial resistance among humans. Next slide. So I wanted to introduce a case of a patient to you, and some of you may be familiar with taking care of patients in hospital, some of you may not be, but here's a case of a patient that I took care of, a 78-year-old lady who was admitted to the intensive care unit with COVID-19. And this kind of a patient occurred in the worst of our Delta wave epidemic. There was a number of admissions to hospital, patients very sick with COVID-19 requiring mechanical ventilation to help them survive. And this patient was in hospital and doing okay from the COVID point of view, but acquired a drug-resistant bacteria while she was in the hospital. Now you say, why should a patient get a new infection while they're inside the hospital? Unfortunately, that happens fairly commonly, and the germs that live in the hospital are highly drug-resistant compared to the germs that live in the community. And this lady acquired a germ, it lives on the skin and in the nose, called Staphylococcus aureus. And this one was highly resistant to antibiotic drugs. We call it MRSA. And so this lady eventually died because of the infection that she acquired with this MRSA bacteria. She survived COVID-19, but because she was in hospital, and because the bacteria that she acquired was highly resistant to antibiotic drugs, she finally died. That is to say, had she not acquired an antimicrobial resistant bacteria, she would have survived from COVID-19. So this case illustrates that this problem is occurring inside hospitals. Standard antibiotics given to this patient would not work because this germ, MRSA, is resistant to standard antibiotic treatments. And that means that this lady had a poor outcome. And if this lady was your grandmother, you would not be too happy with the fact that standard antibiotics did not work to save her life, but rather she died because of a drug-resistant bacterial infection. Next slide. So one of the strategies that we adopt in the province of Newfoundland and Labrador is called antimicrobial stewardship. Antimicrobial stewardship basically means use antibiotics more carefully. Where should we give antibiotics? We should give antibiotics in hospital to people with life-threatening bacterial infections. Generally, we collect their blood, we find there's a bacteria in the blood that's a life-threatening situation. That patient, life will be saved by appropriate use of antibiotics. We do not recommend antibiotics for mild or viral respiratory tract infections. That is, if you're a healthy person in the community visiting your family physician or a walk-in clinic or an emergency room, complaining of pharyngitis or sinusitis, or your child has otitis media, you have acute bronchitis, these minor irritating respiratory tract infections that cause a cough and a sniffle and a scratchy throat, these are viral. They should never be treated with an antibiotic. To give an antibiotic in this scenario is to waste the drug and contribute to the ecological problem. So our objectives: identify unnecessary use and change both the prescriber and the patient's behavior and choices. We want the patient to not request an antibiotic when they should not receive it, because they should be educated enough to understand when an antibiotic is appropriate. And we want the prescriber to be very clear and put up a very strong boundary against the inappropriate request for a drug that should not be given. Remember, a lot of people want treatment that they should not actually receive. And this is part of quality of care and choosing wisely, that we promote appropriate use of all kinds of drugs. Please don't ask for it, and prescribers, please do not prescribe it unless absolutely necessary. And our second objective: reverse the trend of increasing antimicrobial resistance in the province, in the country, and in the world. We're tired of seeing the bacteria become more and more drug resistant. We would like to see that the bacteria would revert to a susceptible state in which the drugs would continue to work in future. That would be our primary objective. And thirdly, we really need to change some old ways of thinking. We are going to show you some trends in antimicrobial use, demonstrating some success in reducing use of antimicrobials, but we still have some concerns where people are requesting antimicrobials inappropriately. Next slide.
So the problem is that on a national level, we are reported to be extremely high users and consumers of antibiotics. And it's reported that we are the highest in the country. But I want you to all kind of take this data with a grain of salt. That this data is not a true representation of our consumption. This national report only documents data from a small fraction of community pharmacies, and Dr. Daley will present some more wholesome data later in this presentation. So you can go to the next slide, Melissa. So quality care kind of took on this endeavor and took on a multifaceted approach to combat the overuse of antibiotics in the province. The first was a public and patient engagement / education. So we wanted to educate the public on the appropriate use of antibiotics and the dangers of overuse of these antibiotics in harms of bacterial resistance. The second was medical education. We wanted to provide clinicians, mostly family physicians and nurse practitioners in the community setting. We wanted to provide them with best practices that came through Choosing Wisely Canada, but we also wanted to provide them with their own data that would give them some sort of self-reflection in hopes that they would change their behaviors on inappropriate use of antibiotics. And finally, after two of these, we would, of course, measure and evaluate to see whether some of these endeavors, including the Antimicrobial Stewardship Committee, to see whether there was some sort of trending and reduction of antibiotics within Newfoundland and Labrador. So some of these are the resources that Choosing Wisely NL and Quality Care NL kind of pushed out to the public and patients. If we look to the far left, this is what we call a vial prescription pad. So we provided this to primary care clinicians so that they can provide this to their patients coming in that will perhaps have the common cough or cold, thinking that they might need an antibiotic. But this will give some sort of education of that you actually have a viral infection and that antibiotics won't give you any sort of benefit by taking them. The top two, you'll see these captions and screenshots that we're drowning in antibiotics. And did you know some viral infections don't need antibiotics? These were YouTube videos that were created by Quality of Care, and we pushed them out during Antimicrobial Awareness Week to provide some sort of education to the generic public. In the middle, we see that no amount of antibiotics will get rid of your cough, cold, or flu. So this was actually a poster that we actually provided to, once again, primary care clinicians, including family physicians and nurse practitioners, that they could actually put up within their waiting room, within their clinics. And finally, we see an information page that is targeted to vulnerable populations. We actually created two of these. One, the one you see within this presentation is aimed at children. So this was an information sheet perhaps for young mothers or fathers coming into a clinic asking for antibiotics for their young child who perhaps just has a common cough or cold. But we also created one for seniors because within the data that we analyze, seniors are very high users of antibiotics within Newfoundland and Labrador. So you can go to the next slide, Melissa. So this is just a short video that Quality of Care created and that we pushed out during Antimicrobial Awareness Week.
Did you know some viral infections can last for several weeks? Antibiotics won't stop a cold or flu, no matter how long it lasts. They can also cause some nasty side effects. It's time we change our habits. Talk to your doctor. Ask, do I really need antibiotics? And take your treatments as prescribed. Choose wisely.
So just as an asterisk for that video, I have no voice acting training. And B, we obviously didn't have a high budget to hire a proper voice actor. So this is a screenshot that you'll see that we provided medical education through what we call audit and feedback. So we acquired information from the Newfoundland and Labrador Center for Health Information for all prescriptions coming from the pharmacy network. So that would include all prescriptions and dispensed drugs. And we looked at antibiotics, and we could look at on a personal level, clinician level. So basically, we could drill down to the data and provide nurse practitioners and family physicians across the province with their own personalized data. And this would be compared to their peers across the province. So what would happen is that each clinician would receive an email from Quality of Care NL. They would click on that. It was unique to that clinician, so nobody else knew about that data, including ourselves, as we were quite blinded to the actual practitioners' names. And then they would click on it, provide their personal information, and then they could scroll down and look at how they have prescribed antibiotics throughout the past year and compared that to the rest of their peers across the province. So you can just click on the next slide, Melissa. So this is an example of some of the graphs that would be represented. Not only did we provide what kind of antibiotics they prescribed and who they prescribed them to by gender and age demographic, but this would just basically show a ranking chart of how they compared to other prescribers across the province. So you can see in our last campaign last year, we provided two sets of data. This was before COVID, and the graph on the bottom was during COVID. And when an actual clinician would actually go through their personalized information, there would be a red dot and a summary table underneath one of these graphs, just giving them a rank and how many prescriptions of antibiotics they prescribed throughout the year. You can go to the next slide, Melissa. Thanks. I'm just going to hand it over to Peter here now.
Thank you. And you're seeing some of the interventions that we're using in the province to try to reduce antimicrobial use. One of the other things that Robert talked about is measurements. So it's very important that we know really how much antimicrobial prescription is happening. So we surveyed the pharmacy network, and we collected 1.5 million prescriptions, and we described what was happening to antimicrobial use over time. And I'm happy to report that you can see reduction in the rate of prescriptions per population in the province over time. Thankfully, the rate of prescriptions declined both prior to COVID-19 and much more after COVID-19 began. So where we may be the highest use province in the country, we're encouraged to see that antimicrobial use may be on the decline. We are convinced this is representative data because our pharmacy network contains every single pharmacy in the province. So we're encouraged by this, although we are a bit worried that as COVID-19 comes to an end or becomes an endemic virus in the country, that this rate of prescription may increase again. So next slide. And we've analyzed carefully exactly what are the trends within the data. For instance, we know that antimicrobial use in seniors and elderly population is much higher than it is among children. And if you look at the rate among children, that's the dark blue line towards the bottom of the graph, both young boys and young girls, that the rate of use in children is declining significantly. So we're happy to see that probably younger parents of young children are becoming aware that a lot of the treatment that they're giving the child is not necessary and can be reduced. On the other hand, among the older folks, if you look in yellow and the light blue color, the seniors and elderly, we are still seeing high rates of prescription of antibiotics. Also, strangely, higher rates among women than among men. Now, that makes absolutely no sense because we don't expect that women should get more bacterial infections than men do, but rather they access care more than men do. So just reflecting maybe inappropriate use. The other thing that we identified was a very, very small number of prescribers who are prescribing enormously high rates of antibiotics, like thousands of prescriptions per year. And we identified a group of 9,000 people living in this province who take more than 4 prescriptions of antibiotic per year. And we wonder, why would anybody require or request more than 4 prescriptions for an antibiotic within a year? To us, that sounds like very inappropriate use. Next slide. And lastly, we actually analyzed this geographically. So we were able to put a rate of antibiotic use onto the map of the province. And curiously, if you look in the darker colors representing the higher rates of use and the lighter colors representing the lower rates of use, we're quite concerned about certain areas. Firstly, rural areas seem to have greater use than urban areas, like in the city of St. John's. Secondly, Springdale is identified as a particular high location. The highest rate of use in the province is in the town of Springdale. And we see other areas that have high rates of use, the Southern Avalon and the South Shore. So we know that this is not uniform across the province entirely. Next slide. So then we would like to give a message to you today. You're logging on because you're interested or increasingly aware of the problem that we're facing, the ecological or global warming type problem that we're getting ourselves into because of the rate of use that we have. What can we do to reduce antimicrobial usage? One thing is certainly to educate people like you and the members of the public, members of the healthcare population. Within hospital, here's some targeted strategies. We can certainly follow the culture results produced by the microbiology lab to help us to reduce the antibiotic use in the patient who's in hospital. We can certainly never give an antibiotic as a prophylactic. Prophylaxis means a preventative treatment. If a patient doesn't have a bacterial infection, there should be absolutely no reason that they should ever receive an antibiotic. That is, antibiotics are treatment. They are not prevention. And we see a lot of this, for instance, in surgery, where antibiotics are used as prevention in people who do not have bacterial infections. Thirdly, we can reduce duration of therapy, where we traditionally would give people 14 days of antibiotics or maybe 10 days of antibiotics. We're starting to realize that if they're better after 3 days of antibiotics, why would we give them 14 days of antibiotics? That seems unnecessary. And that's probably contributing to selection for antimicrobial resistance among the bacteria that live inside us and upon us. So the minimum duration of antibiotic therapy would be appropriate. And that duration is probably individual. So if the patient's in the intensive care unit, they turn around within a couple of days of antibiotics, we should immediately stop. It should not be a standardized duration for everybody. Each patient may be different in the duration that they require. And fourthly, of course, we want to prevent transmission of these germs between patients. And so we do a lot of infection prevention and control, which is to say isolation, gowning and gloving, personal protective equipment, hand washing. Let us not see these germs transmitted in between patients. Let's talk about in the clinic setting. You come to your family doctor, emergency room, you call up 811, speak to a nurse practitioner about what you should do with your respiratory tract infection. We should explain to patients that an antimicrobial is not needed, and that might take some time to convince the patient that, great news, you don't need to take an antibiotic. But doctor, I'm used to taking an antibiotic. Each time I have a cough and a sore throat, I get an antibiotic. Well, we need to change the way you think around the use of these treatments. Well, hold on, that's not okay. I'm used to taking an antibiotic every single time. I take them several times per year. I'm going to find a doctor who will give it to me. And these are the challenges that we face and the way that we want the public to change their view. And lastly, we want to provide reassurance, especially to parents of young children. Look, if your baby is sick with a high fever and an otitis media, then you're very worried that your baby is going to do poorly or even die. But the fact is that the natural history of those mild respiratory tract infections in children is resolution without treatment. So great news, 2 to 3 days from now, your baby will probably be healthy and running around the house as before without antibiotic treatment. So that's education towards prognosis. Next slide. So I hope you take away from today some understanding of the harm of antimicrobial treatment. Antimicrobials may harm an individual person, but the bigger harm is the selection of these genetic changes among the bacteria within the world, which is a slow ecological problem that's increasingly expensive and harmful. It may not harm you yourself when you take the antibiotic, but you're contributing to the kind of global warming problem of all of us in the world. Understand that viral illnesses, especially including COVID-19, should not be treated with any antimicrobial drugs. And the last thing to remember, and this happens in elderly patients a lot, if you have bacteria in your urine, you don't necessarily need an antibiotic drug. Oh, well, that's very strange. Whenever grandmother has a problem or she's more sick than before, we take a urine culture and we grow bacteria and we give grandmother antibiotic treatment. In fact, that may not be necessary. Sometimes elderly patients will pee in a cup and bacteria will be grown, but it doesn't actually mean that they need an antibiotic. So we're challenging understanding in terms of urinary tract infection as well as respiratory tract infection. Next slide. So let me touch on a few common syndromes, and I want to reserve some time for interaction. A few people have put a few things in the chat, and I want to go through those. And I'd like to hear from you also. So you can open up your microphone, you can give us a question, tell us who you are, and tell us your experience with antibiotic use or your concerns, or you disagree with us. We'd like to hear from you. I'll wrap up with a few common syndromes that we need to define and remember. I'll also tell you this, we have a free app called First Line. Go on your app store, find First Line for Android or for Apple, and download it for free and open it up. It contains antibiotic use recommendations by syndrome. And we give this to nurses and pharmacists and physicians, but if you're a patient, you should have the app in your hand as well. Okay, my baby has otitis media, that's ear infection. What should I do? Let me open the app and let me follow the menu, and it'll tell me when an antibiotic may be necessary or not necessary. That is, even before I go see my doctor, I already have some understanding of the condition and what treatment may be appropriate. So the app name is First Line. First Line, F-I-R-S-T-L-I-N-E, First Line. That word first line means the best approach, the first line treatment, the superior approach to your condition. Colds and runny noses. Coughs and colds are common. COVID-19 causes cough and cold. It generally does not lead to serious infection like pneumonia, which is an infection of the lung, but rather an infection of the nose and the mouth and the trachea. That's the upper respiratory tract infection. Colds are caused by viruses. They are common. Most children will get many colds per year. Adults may still get 4 or 5 colds per year. It's February, it's March, you're getting up in the morning, your nose is plugged, your throat is scratchy, you have a fever, you have a headache, you don't feel like going to work, you have a cold. That is not influenza, that is a mild cough and sniffle. Take a day off work, take some hydration, see your pharmacist about some over-the-counter approaches like Tylenol or other things that may be available to you, but do not request an antibiotic. Go see your doctor if you like, sure, but do not request an antibiotic for this syndrome, which is caused by a virus. Next slide. The next syndrome we will talk about quickly, pharyngitis or sore throat. You know the feeling. Boy, I can't even swallow food. I feel like there's burning and pain and scratchiness in the back of my throat. My tonsils are swollen. I may have a cough. I may have a fever. I feel terrible. I'm lying in bed. You have a sore throat or pharyngitis. The doctor looks down your throat with a light and finds a lot of swelling, a lot of redness, a lot of pus on your tonsils and your throat. What should we do about that? Rarely in adults, this is caused by a bacteria called streptococcus or strep throat. When your doctor looks down your throat, your doctor cannot tell if it's a bacterial pharyngitis or a viral pharyngitis. Well, then how can I tell if I need an antibiotic? A swab must be collected. The doctor would put a swab inside the throat, collect the surface secretion, and submit it for a streptococcal culture. Only if the culture is positive would you take any antibiotics, and therefore you can never have antibiotics at the time you see your doctor until you get the lab result from your swab. Be very aware that a doctor cannot look in your throat and tell you you have strep throat. The only way to know you have strep throat is with a swab. Next slide. Earache, where bacteria get inside the tympanic membrane in the inner ear, is a common problem for children, not so much for adults. Children will have a fever, they'll have a headache, they will not want to eat, they'll be more sleepy, they'll be more cranky. And when the doctor looks down the ear canal, the tympanic membrane, the eardrum, is bright red. That is, there's infection inside of the eardrum. Some children get this on a recurrent basis. Most children get it rarely. Now, what do we do with this? We have a viral infection, and the treatment is what's called supportive care. Give the baby some Tylenol for fever, let them sleep more or take some over-the-counter type remedies. They might not feel like eating any food for a day or two. That's all fine. Let the otitis media resolve, not an indication for antibiotics. Next slide. So those are just 3 common syndromes, and we can talk about many other. If you download the First Line app, you can look through the recommendations for sinusitis. You can look for the recommendations for acute bronchitis. This is not the same as pneumonia. Pneumonia is an infection of the lung itself. You take a chest x-ray and you find that there is infection within the lung. That is very different from infection in the nose and the mouth. Pneumonia is an indication for antibiotic therapy. So if your doctor wants to do a chest x-ray and the chest x-ray demonstrates infection deep inside the lung, then you do need an antibiotic. Okay, we're coming towards the end. We're going to wrap up, and I'll take some of the questions, or Robert can, from the chat, or we want to hear from you. I'll just wrap up by saying we have a Provincial Antimicrobial Stewardship Committee. We are committed to reducing antimicrobial resistance by reducing usage of antimicrobials in the province. We're measuring this carefully. We're intervening carefully. We're talking to the prescribers. We're talking to the patients. We want to see an improvement over time. Our committee has multiple representatives, including government, health region, people like pharmacists that know antimicrobials very well, people who do infection prevention and control, people work in the laboratory. All these people contribute to helping this problem. Next slide. And lastly, to reiterate that we are talking today about human antimicrobial use, but we're very interested in antimicrobial use in animals and in the environment, and the transmission of this problem in between all of these three situations. All of this is relevant. Next slide. Good, we'll wrap up there, and we'll open up for some discussion. Melissa, I've been seeing some things coming in on the chat, and I might try to read through some of these, and we can offer some discussion on some of these things. At the top of the chat, somebody named Jason Vanstone had talked about urinary tract infection. I had mentioned that about not necessarily giving an antibiotic for positive urine culture. That is, there may be germs in the urine which do not require any antibiotic treatment. Lana Collins has shared a podcast with us. Thank you for sharing. And we can certainly direct people to look at that podcast. The name of the app is First Line, and you're welcome to download that app. We encourage patients to use the app. Bring the app to your physician. Bring the app to your nurse practitioner. Have you noticed that we have this app? So many users in the healthcare community in the province already, but we also get phone calls from doctors who say, you have an app? We didn't know anything about your app. So please promote the app. Leslie has a question. What about the prophylactic use of antibiotics for treating close contacts of invasive group A strep or meningococcus? Leslie's talking about extremely rare, serious bacterial infections. Invasive group A strep is a life-threatening situation. You'd be admitted to hospital. You'd probably have surgery. Meningococcal infection is meningitis, also a life-threatening infection. She's talking about use of antibiotics for people who are exposed to that patient, that is family or nurses or doctors in hospital. There are extremely limited applications for prophylaxis in those scenarios. Most prophylaxis around those patients is inappropriate and should not be given. But yes, Leslie, there is some indications for very, very limited prophylaxis guided by an infection prevention control physician only. Melissa says, feel free to type your questions. Jason Vanstone, I'm also of the understanding that there is evidence to support antibiotic prophylaxis for surgery, albeit often for shorter duration. Are you suggesting we do away with surgical prophylaxis? We have audited this and talked to our surgeons in Eastern Health and told them this message. Give the antibiotic during the surgery. Never give the antibiotic after the surgery is finished. That is to say, once you close the skin and complete your surgery, the germs are not jumping inside the wound. That is, you want antibiotics during the time when the tissue is open and you're performing the surgery. Once you've successfully closed, there is no indication for post-operative prophylaxis. So the rule there is, yes, intraoperative, no post-operative. Of course, we're talking about clean surgery. If you open up and find pus, that's a whole different, that's an established infection, and that would be an indication for treatment, not prophylaxis. I'm just going through these. Catherine Street, thank you. Has the Antimicrobial Stewardship Committee considered including patients on this committee? They may provide an interesting perspective, especially on how to educate the public. That's actually an excellent idea, Catherine, and I think we should consider that because today we don't have a patient on the committee. I'm going to take that back, Catherine. Thanks for that recommendation. Corey Ox has given a comment, One Health perspective. With the development of antimicrobial resistance surveillance programs, food animal producers are wondering who would be responsible for footing the bill? How do we promote antibiotic stewardship when the topic is as popular as climate change among oil and gas producers? In other words, people who run farming industries, agriculture, and animal husbandry do not want to reduce antibiotic use because antibiotic use in animals and agriculture is profitable. Yes, you are correct. The more antibiotics that are given to animals, the quicker the animals grow. They grow stronger and bigger earlier, and therefore they make more money when they are used for meat. So you are right, Corey, that there's a disincentive from the industry to reduce usage. All I can say is, globally speaking, there is more and more pressure on these industries to change their practice. And the first thing that's happening is measurement. So more and more governments are measuring the rate of usage, and they are influencing towards reduction, even though it is less profitable to the industry.
And I'll just make a comment on that. You'll notice that some of the data that we actually presented earlier was only on human consumption, but that national report actually reports on animal consumption as well. And that kind of three-pronged infographic that Peter displayed. And we'll also note that Quality Care were actually contacted by the chicken farmers of Newfoundland and Labrador, and we actually gave a presentation to them. Only that, we have the caveat of that we only measured human consumption from the Newfoundland and Labrador Center for Health Information, but that kind of group wanted to be educated on antimicrobial stewardship and how they can bring the measurement and evaluation and some of the methods that we use as Quality Care to their industry.
Peter, I'll just jump in here with a couple of questions that came through privately to me in the chat, so you may not see them. Someone has mentioned that the UK has previously talked about moving antibiotic prescribing to pharmacists. Do you feel this would help, and should we look at doing that here?
Excellent question. I would venture to say that pharmacists would be better users of antimicrobials than physicians and nurse practitioners are. And I say that because I work with pharmacists in antimicrobial stewardship for many years. The pharmacist is the expert on the appropriate use of the drug. I would encourage pharmacists' prescription of antimicrobials, and I would expect that we would see reduction in rate of use.
Another one that came in privately there. Sometimes the issue seems to be that people think antibiotics are a bit of a miracle drug. You touched a little bit on it during your presentation, but how do we change the public's view on that? And of course, presentations like this and sharing information like this and public and patient engagement campaigns like what Quality of Care do, getting our local media involved, can all be aspects. Do you think there might be a role for the school system in educating, children about viral versus bacterial infections, and just antibiotics don't work for all of them?
Thank you for that comment. Antibiotics are miracle drugs, and they work in extremely limited situations where they save lives. If you're lying in hospital dying of a bacterial infection, you desperately need an antibiotic drug, and it will save your life. There's no question about it. The problem is we've taken that indication and we've started to slide into other indications. And so now we have minor coughs and colds, and we start to feel like we want a miracle drug too. We do not deserve or benefit from that application. So we have slid. We have over the 60s, 70s, and 80s, we progressively started using these drugs incorrectly. And during those decades, it was okay because pharma was making new drugs over and over again, and we were not concerned. Now, fast forward to today, we have to be much more strict with our usage. Another thing you mentioned was education of children. Great idea. In Western Canada, there's a program called Do Bugs Need Drugs? And that program is in the schools such that young children receive the message early in life. Cough and sniffle, runny nose, sore throat, no need for an antibiotic. Thank you.
I've seen a comment there from Joanne. Joanne says, over the years working in public health, she's had some new moms as clients who've had mastitis. And if it is caught early, the client is taught ways how to empty their milk ducts, etc. Some are prescribed antibiotics for 7 to 10 days, and their symptoms usually clear within 48 hours. But Joanne has indicated that she's had discussions with these clients about taking an antibiotic and the risk to the babies, even the mom developing something called thrush, treatment for which can take up to 3 months or longer. So just to comment, sharing some extra information from a different perspective from new moms and public health.
Thanks, Joanne. And mastitis can be a problem with new moms who are breastfeeding. The milk duct becomes blocked and therefore the milk doesn't flow, and the nipple and the breast can become red and swollen and hot, and the mother can have a fever and it can interrupt the breastfeeding. So mastitis is an important problem. The treatment of mild mastitis is a hot compress, which will allow the duct to open up and let the milk flow to the baby. The treatment of mastitis is not antibiotics. Sometimes mastitis becomes very severe, even requiring surgery. That would be a reason to give an antibiotic to a mother with mastitis. Can antibiotics harm the baby? Thrush is an overgrowth of yeast in the mouth or on the nipple. That's called thrush. Yes, that can be a harm from antibiotic treatment. Thirdly, if the mom takes an antibiotic and gets better within 2 days, why would a doctor give 7 days of antibiotic? That would be unnecessary. You see, we've had this message that we must always finish our course of antibiotic treatment. I disagree with that message. I think if you're better, first of all, did you need an antibiotic in the first place? Second of all, if the mastitis is better in 2 days, stop the antibiotic, return the antibiotic to the pharmacy, don't keep it in the medicine cabinet for later, don't flush it down the toilet where it goes into the environment, return the unused medication to the pharmacy, and you did not need the full duration. So that's my approach to duration.
Thanks so much, Peter. I'm just conscious that we're coming up on our 1 o'clock time there, but we did have some great discussion and questions from the chat. So we thank all of our attendees, most of which are still online. So thank you so much for sticking with us all throughout the whole session. I'm going to post one link in the chat here now. It's just a webpage from Eastern Health, which provides some patient education about antimicrobial resistance, another place you can go to find some more information. I will also type in our email address, and you can reach out to this email if you have a question for Robert or Peter, and I'll be sure to connect with either of them to get your answer, or if you have anything else that you'd like to share with us, we're happy to hear from you at that email address, info@qualityofcarenl.ca. So thank you very much to our presenters and to everybody who joined us online this afternoon. Happy World Antimicrobial Awareness Week and happy Research Week for those of you joining from the Memorial University community, and have a great rest of your day.
Thanks for joining.